Welcome, everyone. I am Bob Wurzelbacher, the director of the Respect Life Office for the Archdiocese of Cincinnati, and this is our video podcast series that we call Being Pro-Life. Each month, we discuss a different topic in the Respect Life arena. We'll hear a personal story from someone deeply affected by that issue, and finally, we'll share ways that you can get involved. Today, we have a special episode on the COVID vaccines available here in the United States. There are still a lot of questions about them, about their efficacy and their relationship to abortion. As always, we have a special guest. Will you please introduce yourself?
Hi, I'm Dr. Ann Moelle, and you may have seen me before on the podcast speaking about some other pro-life issues through my work with Elizabeth's New Life Center. But today I'm here to speak about my other hat that I wear, which is with my background in family medicine. I'm also working in a clinical research office here in Dayton. And we've been involved in clinical trials for one of the COVID vaccines.
Well, thank you, Dr. Moelle, for being with us today. So let's begin by clarifying a little bit that connection between abortion and these vaccines. Now, we know there's a connection. Maybe you can more clearly explain in lay terms, are the cells of aborted fetuses in any of these vaccines?
Yeah, that's a good question. I've had a lot of friends expressing concern. And in fact, when we first started looking at a contract to take on the Pfizer study that I've been working on, that was one of my concerns as well. So there's a couple different ways that the vaccines can be linked with the issue of abortion. There's some cell lines that were derived from aborted fetuses decades ago, some in the 1960s, 70s, or 80s, that have been reproduced and propagated over the time. And these cells are used in different various research, including development of vaccines. The ones that we have now for emergency use authorization are the Pfizer vaccine, the Moderna vaccine, and most recently the Johnson & Johnson vaccine. The Pfizer and Moderna vaccines have used cell lines from aborted fetuses in their testing of the vaccines in the laboratory. The Johnson & Johnson vaccine also used these cell lines in their research and development, but the difference there is that they also use cells that are human cells that are derived from these aborted babies in their manufacturing process. The Moderna and Pfizer vaccines, they don't use any cells in their manufacturing, so there's no chance of any human cells or fragments of human cells or fragments of DNA in their vaccines at all. The Johnson & Johnson vaccine and the Astra-Zeneca that's coming along in their studies as well, both use the cells in their manufacturing process. And this is why those vaccines are made with a viral vector. It's a weakened adenovirus. It's like a virus that causes a cold, but it's weakened, so it can't make you sick. But they've used this virus to put the DNA from the coronavirus that codes for the spike protein that's on the surface of the virus. They put that inside an actual live virus that's been weakened, and then that's what is injected into your arm. Then the virus can get into your cells and get the DNA into there to allow your cells to make the spike protein. But in order to make a virus, viruses can't replicate on their own. They have to be grown in a cell. So that's why they need to use the cells in the manufacturing process. Now, some vaccines are made in other kinds of cells, like canine cells or chick embryo cells. I even read about one the other day they're using some kind of insect cell to culture the virus. But in this case, with those two vaccines, they're actually using the human embryo cells from these aborted fetuses. Now, one thing you should also know is that these babies were not aborted in order to obtain tissue for research or drug companies to make money. These were people who chose to have an abortion for whatever reason, and they happened to get the tissue, and they learned that they could propagate these cells for generations and generations and generations. So there is a connection. It's a remote connection. It's something that we shouldn't want to have to do with any of our medical research or treatment. It should be something we should oppose because it's human dignity. But the connection is remote. And there's two issues. One is the connection to abortion, and the other issue is it's safe to make vaccines in human cells. We could talk a little bit about that too with the Johnson & Johnson vaccine. Their letter from the FDA to approve for emergency use lists the ingredients of the vaccine. And what the last line there does say, it could contain fragments of the culture cells or DNA from the culture cells. Now, it doesn't say human cells, but that's basically what it is because the culture is human cells. So We don't know about the safety of that. There's some people who are concerned about the safety of the possibility of any kind of fragments of human cells being in vaccines. That's something that needs to be studied more.
Certainly interesting. So at least with the new Johnson & Johnson and the AstraZeneca, those used aborted fetal cell tissue cell lines in the manufacturing process.
Right.
So both of those could have some DNA in the actual vaccine, you're saying. But the Moderna and the Pfizer, that was only used in research and testing. And so there absolutely isn't going to be anything like that in those actual vaccines, right?
Right.
Okay, so now we probably all know the USCCB has been pretty clear in telling us that very specifically the Moderna and Pfizer vaccine are less morally compromised, because what we already talked about, than the Astra-Zeneca and now the new Johnson & Johnson vaccines, because those former two employed the use of those compromised cell lines only in the testing. So it's even more remote, the connection. Now that, plus the lack of a better alternative and the seriousness of the current pandemic, leads the USCCB to say that it's acceptable to justify their use. If you have an option, you should choose the Moderna or the Pfizer, but if you don't have the option, it's acceptable to use whatever's available to you. So do you agree that the situation is serious enough to justify everyone taking it? Or does this really only apply, if you're in a nursing home, if you're elderly, if you're in a susceptible group, then it's okay for you to take one of these vaccines. But does this really apply to everyone or only to the vulnerable?
That's a really good question too. And my short answer is it applies to more than just who you would assume to be vulnerable. Maybe not everyone, because there may be some people who can't take these vaccines because they have severe history of allergies or some other kind of autoimmune reactions when they have vaccines. They have to be on some kind of immune suppressant where they couldn't respond well to the vaccine. So there's some people who, for some medical reasons, can't take vaccines. But it's not just important for people who are most susceptible for serious illness to take these vaccines, because the people who are most vulnerable have to be cared for by other people. For example, if you only give them to like teachers or people who work in nursing homes, you're going to miss a lot of the people who could transmit the virus to people who are needing to take care of people. So the more we can do to start decreasing the pool of the virus out in the whole community, I think the better off we'll be, because people who won't get very sick from COVID could give it to people who can get very sick from COVID. And it's hard to get everyone covered. And some of those people who can get very sick might not have as good of an immune response, even with the vaccine. There's still a lot we don't know. How long the immunity will last with the vaccine, if people can transmit it after they've gotten the vaccine. We don't really know about asymptomatic carriers. It's something we're studying. So the problem is still really serious. I mean, we've had over 500,000 deaths in the US since this started. We are starting to see a decline in that since the vaccine started coming out in January. But I was looking at our stats in Ohio most recently. We've had close to almost 1 million cases of COVID in Ohio that we've tested for. I think there's probably more than that people haven't even gotten tested. We've had 17.3 thousand deaths in Ohio so far. And the cases are going down. And the deaths did take a drop in January, but I've seen it plateau. So we're not there yet. So I really think that the more people can get protected from the virus, the better we'll be.
So maybe we could still use a little more clarity. You did say that we're not sure about the answer to some of these questions. It's my understanding that getting the vaccine is, as far as we know, is primarily about not getting very sick if you're exposed to the virus. It certainly is not related to not passing along the virus, or at least we don't know that it stops passing the virus in any case. So again, if the important thing is that people who are particularly susceptible don't get the virus, or at least don't get a bad case of the virus, then why is there still a lot of concern about those of us who aren't susceptible passing it around to each other, as opposed to the focus simply needing to be just get vaccinated, those who are in susceptible groups with asthma or the elderly or who have other conditions that are going to be exacerbated by COVID? Why is it that everybody needs to get the vaccine, or at least a large percentage, in order for everyone to be taken care of?
I don't know if I have a better answer than but there's a couple of different issues, that not just protecting people from getting really sick or dying, but you're talking about quarantines, time off work if you get exposed. There's a whole lot of economic impact that we have that we could go into too. And then also, if you protect some people, but not everyone, and the virus is still circulating out there in the community, let's say among children, among people who didn't get vaccinated because they don't feel they're very vulnerable to getting super sick from it, then you got more time for the virus to also mutate. We get more variations going on, and then we may make it harder for the vaccine to be effective. So that's another reason why it's a good idea to get more people vaccinated quickly, because if we squash this virus quickly now, it has less of a time to mutate, less of a time to get more variants out there that are going to be another challenge for us.
That part makes a lot of sense to me. If getting more people vaccinated, even if they're not susceptible, that's going to reduce the mutations and the variants of this virus and reduce the chances that the current vaccines will become ineffective, then that's very sensible. So
the other thing that you have to realize is that there's not just a clear dividing line between the people who are real susceptible and the people who are not. I mean, a lot of people are saying, well, it's only the elderly or people who have a whole bunch of medical risks that are getting sick. But we also have very young adults that have gotten sick and have had a hard time recovering from this virus. They might not have died, and there have been some who died, but people who were perfectly healthy that you never would have suspected are now having heart conditions after recovering from COVID, or there were athletes that aren't even able to breathe well enough to run. I mean, there's what they call the COVID long haulers that are having more trouble recovering. It doesn't, just because you're 20 years old or 30 years old and you're in perfect health doesn't mean you couldn't end up having COVID and having long-term consequences. It's obviously been more deadly in the elderly, but it's not necessarily only the elderly that are vulnerable. And when you lose someone who had a whole life ahead of them, we're really pro-life. We care about all those lives. We care about the lives of anyone who, one life lost is too many. So everything we can do to protect everyone, I think, is better. I don't think we should mandate the vaccine, but I think there's strong arguments for people who seriously consider doing the vaccine, not just for their own protection, but for the common good.
Right. So let's talk about that a little bit then. Let's say, a teacher at a Catholic school, they want all their teachers to get vaccinated, perhaps, but you have a few teachers that are still, they really want to wait until a more ethical vaccine is developed that is not currently on the market, right? And in the meantime, they want to take advantage of this opportunity, if you will, to really send the message to everybody developing vaccines that it needs to be ethically perfect, if you will. It needs to have no connection with abortion, or I'm not going to take it. So if a Catholic school teacher is in that situation, what level do you think a Catholic school should be encouraging teachers to take the available vaccines, and what should they do with teachers who don't want to take it?
I think that the Catholic schools should probably follow the recommendations of the U.S. Conference of Catholic Bishops as far as the moral and ethical considerations. If I could read it, if you don't mind, it says, in view of the gravity of the current pandemic and the lack of availability of alternative vaccines, the reasons to accept the new COVID-19 vaccines from Pfizer and Moderna are sufficiently serious to justify their use, despite their remote connection to morally compromised cell lines. In addition, receiving the COVID-19 vaccine ought to be understood as an act of charity toward the other members of our community. In this way, being vaccinated safely against COVID-19 should be considered an act of love of our neighbor and part of our moral responsibility for the common good. I think that sums it up pretty well. Now, that people should be made aware of that thought process. But if a teacher has decided that they don't feel comfortable with that, they want to wait till something morally comes out, I think that they should be given that choice. That's my personal opinion. I'm not speaking for any organization at this point, because there still is some things we don't know about all these vaccines. We're still researching, we're still following people long-term for, how safe they are, which looks super safe so far. We expected, if we were seeing any safety issues, we have seen them already. We don't know how long they're going to work. We don't know if the vaccines that are still in development are going to be better. So someone says, I really don't like the attachment with the abortion issue, and I really want to wait. I really don't think they should be forced to do the vaccine. But, they're still going to have to be cautious. I mean, they're going to, wear a mask for longer. They're taking a little bit of a risk of their own life. And then they have to consider, what if I do get COVID from one of these children who didn't know they were carrying it? then I'm out of school, I'm quarantined, I'm putting the school in a bind to find a substitute teacher to keep these kids on track with their learning. So their choice to not vaccinate themselves does have implications they have to consider.
All right, that makes a lot of sense. I do want to move to masks, but before we do, there probably should be, people are probably wondering, we kind of jumped over this. So you're actually involved with the research in the Pfizer, because you have some connection with that. And Pfizer is one of the companies that has a connection to abortion in the testing phase as well. So maybe you can clarify for us, what is that level of testing with the drug that you're testing, and what is your level of complicity with the testing that Pfizer
Right.
is doing?
I know it's a thing to sort out in your mind, a moral dilemma. So I work for a clinical research group in Dayton, and we don't develop any of the drugs that we are testing. We are just hired through an intermediary that runs clinical trials for different drug companies to be one of the sites of among hundreds around the country and around the world that are running clinical trials for all kinds of drugs that are in development, including vaccines. So when the pandemic hit, ironically, our work totally died down for a couple months because a lot of people couldn't continue to do their work because people couldn't come to the office. People who were in studies couldn't come to the office to do what they needed to do. But with those vaccines in development, Pfizer had one that was ready to be tried in people in their phase 2-3 trial. And we were one of the sites that was chosen to run their trial. So we don't design the drug. We don't really even design the trial. We just conduct their protocol in our population in the area. And one of the reasons that our office was chosen was because we had a high prevalence of COVID going on in our community at the time. And that's one of the things they needed to have enough people that were in the study, possibly being exposed to COVID, to see who was going to get COVID, if it was really going to make a difference, if people who got the vaccine versus placebo, because half the people got vaccine and half got the saline injection. We wanted to see if there's a difference in those groups. So I'm employed by that group. And so remotely, I'm helping Pfizer find out if their vaccine works or not. I feel good about the work that I've been doing. I don't like the fact that drug companies still find it necessary to use cell lines from aborted fetuses for their research. I think we should speak out about that, try to encourage them to find other ways to do this research. But once we have a pandemic and there's a vaccine that's needed to save people, I mean, more than 2.5 million people have died from COVID in the world so far. This is a serious problem that we had to work toward finding a way to save people, to relieve our healthcare workers. I don't have much heartburn over being part of the vaccine study, although I do think we need to still advocate for research not to use these tools that have been so commonly used over the last couple of decades.
Right. So Dr. Moelle, so obviously the research that you particularly, involved in conducting, it was just on people. It sounds like whatever research is used on the HEK line, isn't that what it's called, on that particular infected line? Is that an earlier stage of research that is done by somebody else before it comes to you? And then what is it?
This is all in the labs when they're trying to develop a new vaccine. They're using some cell lines sometimes to develop the drugs, sometimes to test the drugs to see how they're working. So one thing I heard that they do is take some of these fetal lung cells and put them in a mouse so that the mouse lungs now have human cells in them to see how the vaccine is working in the human tissue in the live mouse who's had a vaccine or who's been exposed to the virus. So it's all happening in a lab. It happens way before it ever comes to us. I mean, what we get in our office is the same thing that people have been receiving now in the public, the drug that's being tested. So,
and again, yours is the Pfizer, which did not use human DNA in any of its manufacturing at all.
Right. Or even in the development, just in the testing in the lab.
Right. Okay. So many of us have friends and family at this point, the beginning of March here in 2021. My mother has been vaccinated. There are teachers, they would have been vaccinated. So a certain percentage have been vaccinated already. So does this mean now that they can stop wearing masks, or I can stop wearing a mask in order to visit my mother, for example, or we're not at that point yet?
I don't think we're at that point yet. And I know it's disappointing for people to hear that. It doesn't mean we'll never get to that point. I know I've heard some people saying, well, why should I bother to get the vaccine? Because if I still got to wear a mask and I still got to restrict myself, then what's the point?
Right.
But we have to see the numbers of deaths going really down. And there's certain situations that people could use their prudential judgment to say, look, I feel pretty protected. The person I'm visiting has also been vaccinated. Like for example, my own personal situation, my dad is 87 years old. He got vaccinated and he's past his 2 weeks from vaccine. I've been vaccinated and I'm past my 2 weeks from vaccine. During the whole time of COVID so far, every time I went to his house to help him with something, I wear a mask, I wash my hands, I don't go within close contact. And I visit with him at a distance because he's lonely. He lives alone. And so I can sympathize with people who are worried about their family members who are isolated. But I've been being very cautious about that because I don't want to potentially get him sick. He's got, he's elderly, he's got health risk factors, and I'm around a lot of people. But now that I've been vaccinated, he's been vaccinated, and we're both good, I find it comfortable to not have my mask on when I'm in his house. I think there's something valuable to see people face to face. So, I still wash my hands. I'm still careful about, not being right in his face or anything, but we have some protection there. The chances of us both having a risk of getting COVID from each other or whatever is pretty low, but there is still a slight chance. So one thing we don't know is how people might carry the virus after they've been vaccinated and not have any symptoms, but still be able to transmit it to other people. That's being studied right now. So it's not like I hear people say, well, the vaccine doesn't keep you from transmitting it to other people. We're studying that right now. So the verdict is still out on that. I think we're going to find that it probably does decrease transmission, even asymptomatic transmission. But right now at my office, we are actually studying that and collecting data on that.
So let's talk then about that 95%. So of course, we heard the Pfizer and Moderna anyway are 95% effective, but what does that mean, right? I don't think it means specifically that you only have a 5% chance of getting COVID if you get the vaccine, right? It doesn't mean that.
That's a really good question. So in the studies, they compared the number of people who got the placebo that came down with COVID versus the number that got the actual vaccine that came down with COVID. And the difference of that showed that the people who didn't get the active vaccine had a higher chance of getting COVID than the people who got active vaccine. In fact, the people who got active vaccine have about a 95% less chance of coming down with COVID than the people who got placebo. So compared to people who aren't protected, getting the vaccine gives you about 95% less chance than they have. Does that make sense?
So was everybody tested or how did that work since you were involved in the testing? Did you just see if people felt sick, they got tested, or everybody in the group got tested?
Initially, when people came in, they got a nasal swab done before they got their first vaccine. And these people all had to be asymptomatic at the time they entered the study.
Okay.
And so that was to find out if anybody was carrying COVID and didn't know it. They also got antibody levels checked at that time. But when we were collecting cases of COVID after vaccine, the way we determined those was with symptoms. And those symptoms included fever, chills, cough, shortness of breath, sore throat, diarrhea, vomiting, loss of taste or smell, and body aches. So if they had any of those symptoms, they were supposed to report them, and they had to do a diary every week to tell us about if they were having symptoms. But then the question of, is it possible that people are carrying the virus and are asymptomatic? And then they added a new arm to the study of having people volunteer to do swabs every 2 weeks when they're not having any symptoms. So that's what we're collecting now. That's the information that's not processed yet.
Okay. So then once they showed symptoms, then they got tested, and then that's where the 95 versus 5% comes from. People who had symptoms were tested and tested positive.
Right.
Are there numbers related to, I don't know, there were more people with symptoms who were in the placebo group as well? Or, a high percentage of people with symptoms didn't end up having COVID who were in the vaccine group, or those sorts of questions?
Oh, that's an interesting question. And I don't know that I can answer that. I do know that, there were a lot of people who reported symptoms on both sides of the spectrum. And we were blinded at the time. So I didn't know when someone was reporting symptoms and I had to talk to them on the phone. I had no idea if they had placebo or active vaccine. Right. But now that our subjects have become unblinded so that the people who didn't get active vaccine have the opportunity to get the vaccine, because some of those people are in the risk groups. Now that we're seeing that, I can look and process a little more about what was going on. And I would say there was illnesses in both groups that were not COVID. that tested negative. People had some other kind of
Right.
virus or
Right.
some other illness that wasn't COVID. And our threshold for symptoms was pretty low. I mean, they could report that they had one episode of diarrhea and they were still doing a nasal swab.
Right.
Anything on that list, a little sore throat, they were tested.
Right. Okay, so Dr. Moelle, we kind of touched on this already because some people are questioning how serious this is. You've certainly had people quote numbers about deaths from COVID versus deaths from the flu, any other flu. Nobody, gets quarantined over the flu. So why would you say that COVID is different from any other case of the flu when there are numbers that suggest it really isn't any worse? What is the why are we closing everything down over COVID?
That's a good question. I've heard that a lot too. So one of the things that you have to think about with this virus is that it is a little more deadly than the flu. I mean, we are having more people with serious illness, hospitalizations with this than the flu. But even if it was only as deadly as the flu, let's say, just throw out a number like 0.1% of people who get the flu die from the flu. If it was the same for COVID, the issue is that flu is a known entity. There's a lot of people who have some immunity to the flu, and we have a vaccine for the flu. So even though it can be deadly, we have a lot of people who have protection against it. So we're going to have a lot less people come down with the flu every year. So consequently, because there's some immunity out there and there's a vaccine, there's less people that get the flu. So there's less people that will die from the flu. And typically in a year in the US, I think we have anywhere between like 20 and 60,000 deaths from the flu. We've had in our country over 500,000 deaths from COVID so far in this year. Why is that? Even if the chance of dying from COVID when you get it is no higher than with the flu. It is a little more, but let's just say that it wasn't any more deadly. The problem is a lot more people will come down with the COVID virus because there was no one who saw it before. There was no immunity. There was no vaccine. So you have a lot more people potentially that can get that virus. So that's why it's a big, serious problem. It's not like a flu outbreak in a particular season. And you can just say that by the number of people who have died in our country from COVID. It's 10 times as many in a year that would normally die of the flu when we have a bad flu epidemic.
And I understand that part of that also has to do with COVID in general transmits much more easily.
Well, and that's partly because there's a lot of people who are partly immune to the flu or have immunity to the flu. So if you have the flu and you're around another person, you might only have 20% chance of giving it to them. I'm just throwing out a number. Right. Whereas if you have COVID, or you might only spread it to one other person. That's kind of how they describe it. Versus if you have one individual with COVID, they might have a potential to spread it to 3 or 4 other people because the people that they're around don't have any immunity. Now that we're getting vaccines on the scene, oh my goodness, I think we're seeing some light at the end of the tunnel. We still have a long ways to go. We still have a lot to learn. So that's why I think we still need to take this really seriously, do what we can to try to keep ourselves healthy, realizing that being with our loved ones is important, getting kids in school is important, getting people back to work is really important. So all the things that we can do to try to help, and one of the tools is the vaccine, I think we should seriously give consideration to as part of our responsibility for each other.
Well, thank you, Dr. Moelle, for being on the show here today to talk about these COVID vaccines, their efficacy, their relationship to abortion, and the importance of certainly considering taking this vaccine just in order to help protect all of society and the whole population from something that is probably more serious than maybe many of us might think it is.
Yeah, thanks for having me. I've been happy to be here to talk with you.
And I want to thank all of our viewers and listeners for tuning in on this episode of our Being Pro-Life series. Head to the website to view all the resources talked about on this episode at www.catholicaoc.org/beingprolife. Thank you again for joining us today. I look forward to being with you next time.